welcome to the Friday morning meeting presented by the Division of Nephrology. It's a pleasure to introduce Dr. Johannes. She is one of our two fellows who have come through the CERT-NEF exam, which I can assure you is a proper exam. So congratulations. He's about 43 days away from being a real nephrologist. So she's going to enthrall us with compliment. It's not always your friend.
Morning, everyone. So I'm Johannes, and today's talk is about complements and the kidney. So I thought that this was an interesting case, as we've seen one or two patients in the last few clinics that's been diagnosed with this disorder, and all the juniors seem to be very confused about it. So I thought, let's go through a case, discuss it, and then you guys will be reintroduced to this entity again. So let me introduce to you Mr. BB. He's a 32-year-old male who presented with nephrotic range proteinuria and renal dysfunction in June of 2021 to a private nephrologist. He had no significant past medical history. He's of sober habits, and he has no known family history of renal disease. So he reports he went to his GP with swollen legs, who then did some basic tests and referred him to a nephrologist. On presentation, we can see that he already had a range creat of 200 and he had 5 grams of proteinuria. So at this point, his urine showed 4 plus protein, 1 plus blood, 9 leukocytes, 11 erythrocytes, and no casts. He also had an HbA1c of 5%. His ANA was negative. His double-stranded DNA was negative, and he was also HIV negative. So at this point, his nephrologist decided to admit him for a renal biopsy. So this isn't the exact histology of Mr. BB, but it is exactly what was described in the Lancet report of the biopsy. And it's what you'll typically see in a membranoproliferative glomerulonephritis. So as you can see, this is the glomerulus, and there's some mesangial deposition with a nodular appearance, which looks like a bit like a bunch of grapes, and most importantly, the double contour formation around the capillaries. And this is what they described they saw on the electron microscopy of Mr. BB, which is the typical subendothelial deposition on the electron microscopy. And this is an example of what they described in the immunofluorescence of Mr. BB, which is positive for C3 staining and also deposits in the mesangial area. So following the biopsy, which is at this point, Mr. BB was started on Prexim and Zocor for supportive care, along with prednisone, and as you can see, there was no improvement in the degree of proteinuria until July 2023, at which point he was referred across our clinic. He was seen by us in August of 2023, and at this point he was started on mycophenolate mofetil, and there was still no improvement in his degree of proteinuria. So this brings us to the talk of today. Most renal diseases are based on a histopathological classification, which basically groups all the diseases into what is seen on histology. Membranoproliferative glomerulonephritis is a pattern of glomerular injury defined by subendothelial and mesangial deposits of either immune complexes or complement factors, along with this proliferative changes in the glomeruli. So historically, these entities have been divided into different groups according to the electron microscopy that we see. Historically, there's the type 1, which refers to the presence of mesangial and subendothelial deposits. And immunohistology can reveal either the presence of immunoglobulins or complement in this type. Next, we have type 2, which is also referred to as dense deposit disease, and was characterized by the mesangial and the intermembranous extension of the electron dense deposits. This entity was first described in 1963, and it was recognized because of the extensive electron-dense material that completely fills up the glomerular basement membrane. And evidence from then on already suggested that complement and abnormal control of the alternative pathway of complement was responsible for this disease. Lastly, we have type 3, which is the presence of not only subendothelial and intermembranous electron-dense deposits, but also subepithelial electron-dense deposits. So as you can see, this group of the glomerulonephritis, membranoglomerulonephritis, divides the different classes according to the area of the glomerular basement membrane that was involved in the deposits. So as you can see, and as I just mentioned, type 1 was just subendothelial, type 2 was extension into the intermembranous area, and type 3 was involvement of the subepithelial area. With the increased access to immunofluorescence, it was evident that this classification didn't take into consideration what specifically composed these deposits. And therefore, this entire group of GNs was reclassified in 2013. So this reclassification was based on whether this was immunoglobulin or complement-mediated associated, or whether this did not involve either immune complexes or complement. And currently, this is the new classification, and it classifies this group of disorders into either immunoglobulin or immune complex mediated, complement mediated, or the membranoproliferative pattern without immunoglobulins or complement. And although we say this is new, this reclassification kind of took place in 2013, 2014. So it's actually relatively not new if we're talking about new things. So this image once again reiterates that it was the immunofluorescence that led to the change of the classification. And once you then get the immunofluorescence, you can then
I'm sorted. I thought the meeting would start. Hadn't started, but it started now.
Okay, so you started on your online.
I'm sorted. Thanks, man.
Okay, just remember when you don't forget to click on the thing that was in.
Yeah, must I click on chat? So
chat. You'll see chat at the bottom of the screen, and then will come up. So then once you,
but it will only, yeah, it will only come up if you click it.
No. They only did it and put it up at the end of the meeting.
Yeah, but it comes automatically on the screen.
You might have to click on it twice, one to register last week, this week. I couldn't do the registration for this week.
Yeah.
And then go back and click again on this week and do the registration for last week.
Thank you so much. Okay, thanks, Ahmed. I'll talk to you again soon. Okay. Thanks, man. All right.
The second group, which is the complement-mediated group, as I said, C3 or C4 glomerulonephritis or dense deposit disease. And then lastly, the group of the membranoproliferative pattern without immune complexes or complement, which you can see there are numerous causes, of which most importantly we see TTP, APLS, radiation nephritis, also antitrypsin deficiency. So the first group is the immune complex associated group, and usually they stain positive for IgG or IgA or IgM or lambda or kappa on the immunofluorescence. And the reason that this is important is because the specific stain that they stain positive for can hint to the etiology of the disorder. Here are just some typical examples of what can be seen on staining and how it links to this or to the etiology of this group of disorders. On your right-hand side, you can see that there's positive staining for kappa in the mesangial and capillary wall area. And similarly, this stain would generally stain positive for IgM and is generally associated with multiple myeloma or monoclonal gammopathy. In the middle, we have an example of an IgG positive, also commonly seen in a post-infectious GN. And then on your left-hand side, we have basically irregular segmental capillary wall and mesangial deposits that the differential should include a proliferative GN with monoclonal deposits, or if there was full house immunoglobulin staining in a picture like this, you would also consider something like SLE. So it's important to note that the majority of cases fall into this group of the immunoglobulin or immune complex mediated disorders. So the pathophysiology, generally what happens is you get chronic infections which lead to antigen or antibody immune complex formation. You get an increase in the levels of immune complexes in autoimmune diseases, or you get the IgM and IgG complexes which form in cryoglobulinemia, and then also the monoclonal immunoglobulins in monoclonal gammopathies, which all lead to deposition of these in the kidney, which then activates the classical pathway of complement, and this leads to deposition of C1q, C4, and C3 in the glomerulus. This deposition of the C1q, C3, and C4 in the glomerulus starts the injury phase. As you can see over here, the entire complement gets deposited in the actual glomerulus. This is then followed by the proliferative phase, where there's an influx of the leukocytes, which lead to damage of the capillary walls of the glomerulus and cause the release of cytokines and proteinases. And this then disrupts the basement membrane and also leads to podocyte food process effacement. This is then followed by the reparative phase, which basically you get changes and new formation of basement membrane with the entrapment of the immune complexes, the complement, the cellular elements, and material matrix, forming the typical double contours along the capillary walls. The next group comprises of C3 positive staining, and this image shows the variable patterns that you can see in positive C3 staining. So basically, this is the complement-mediated group. And as you saw in the previous slide, those were all images that stained positive for C3. But there's another more rare entity where they all stained positive for C4 only. The C3 glomerulopathy is a term that was introduced in 2013, and it was used to encompass all the GNs that were characterized by the accumulation of either C3 or the metabolites later on in the complement cascade. So none of the C1q or C4 prior to the development of the C3. So complement, as you know, induces an inflammatory response that results in phagocyte chemotaxis, opsonization, and lysis of the cells and the microorganisms. It can be activated via the lectin classical or alternative pathway. And they all the pathways then converge in the formation of the C3 convertase, which in the presence of factor D and factor B associates with more C3 convertase and inevitably creates more C3 convertase and forms an amplification loop. The C3 convertase itself is then either deposited in the glomerulus, or it combines with C3b and forms C5 convertase, which then activates the membrane attack complex on the cell surfaces and leads to cytolysis. In C3GN, the problem is dysregulation of the alternative pathway, leading to amplification of the C3 convertase loop. So normally the alternative pathway is continually active at low levels, but there are multiple complement inhibiting or regulating proteins which normally stop overactivation of the production of C3 convertase or C5 convertase. And commonly the inhibitors that we do find that stops this process is CFH, CFI, MCP, and factor H related proteins. So dysregulation of this alternative pathway can occur for a few reasons, and it's either because of mutations in the autoantibodies to these complement regulating proteins or inhibitors of these or mutations in the inhibitors of the alternative pathway. Following the deposition of the C3 or complement, the proliferative and reparative phases of damage occur similar to that in the immune complex mediated glomerulonephritis. So just to reiterate, the C3 convertase or C5 convertase gets deposited, and then there is the activation of the membrane attack complex. Following this, you then get the infiltration of the leukocytes, which then cause capillary wall damage and the release of cytokines and proteinases, which then leads to endothelial cell damage with glomerular basement disruption and podocyte effacement. And then following that, you get the same reparative phase where you get the formation of the new basement membrane with the entrapment of the complement factors, other cellular elements, and the matrix material, forming once again the typical double contours along the capillary walls. So as you can see, and as I should probably point out, despite this all being classified into either C3 or C4 GN or C3 or C4 disease, there are numerous steps along the way which could be responsible for individual disease forming this group of umbrella term of C3 or C4 disease. And commonly what can occur is you can have variations in C3 or C4, like C3 nephritic factor abnormalities. You can get factor H, I, or B autoantibodies, inhibitors, or mutations. And you can also get allelic variants in factor H, C3, and MCP, which can each be identified as an individual disorder and should theoretically be managed differently. So this group of disorders can then present in the kidney as either nephrotic syndrome, nephritic syndrome, or RPGN, TMA, which most commonly is the atypical hemolytic uremic syndrome, or end-stage renal disease. So how do we approach these patients? So the most important thing is to get a biopsy. And once you have a biopsy of these patients with the immunofluorescence, you can then divide your approach into either the immune complex mediated group or the complement mediated group. Importantly, in the immune complex mediated group, you need to then exclude infections, autoimmune diseases, of which SLE is the most common, but there can also be Sjogren's or RA associated with it, and then malignancies. Once you go into the complement arm, you also have to exclude all the causes of the immune complex glomerulonephritis, mostly for completion. And then if you have excluded all of these, you then need to look at mutations in either antibodies to the complement factors or mutations or antibodies to other complement regulating proteins. So the optimal management for this rare group of disorders has actually not yet been established, and the treatment focuses primarily on supportive care. So that would be measures to ensure good health, along with the use of ACE inhibitors or ARBs for proteinuria and also blood pressure control. The use of lipid-lowering agents should be considered, anticoagulation where needed, and most importantly, to avoid nephrotoxins in these patients. So additional measures that should be considered in this group of patients are generally guided by the clinical presentation. So if the patient presents with nephrotic syndrome, the treatment of that patient is mostly the supportive care. If the patient presents with nephritic syndrome, there should be consideration of immunosuppressive agents. If they present with an RPGN, they definitely need immunosuppressive agents. And patients with already low GFRs, the treatment once again is mostly supportive. The aim of treatment in this group is to reduce proteinuria and also to delay progression to end-stage renal disease. So the reason that we do consider the use of immunosuppressive therapy in these patients is to inhibit the cellular immune response that is associated with the C3GN, as I previously described. We hope that the immunosuppressive therapy can also decrease the autoantibody production and thereby limit the C3 and C5 convertase. But from evidence from studies show mixed results. They have concluded from numerous case reports that corticosteroids alone do not reduce the progression to end-stage renal disease in this group of patients. There are some case reports that allude to the use of cyclophosphamide and its benefit. And there's one large study, and by large, I mean like 13 patients from Spain, where they found that MMF was beneficial. And basically, the questions that we were left with was, did this group of 13 patients all have the same genetic allelic variant? And that's why they all responded to the MMF. Or were they all caught really early? And that's why they responded to the MMF. The results of MMF actually working in this group of GNs have not been reproduced in other cohorts. But nonetheless, this table basically shows what KDIGO recommends, where essentially they do recommend that if you present with nephritic syndrome, you consider the use of MMF. And if you present with a rapidly progressive glomerulonephritis, you consider the use of cyclophosphamide. Plasma exchange has also been considered for therapy in these patients, and some case reports do describe favorable outcomes with the use of plasma exchange, especially when it's used in patients with an acute kidney injury. But they're not sure whether it's beneficial in patients that do not have an acute kidney injury and have any of the other presentations, or when you actually stop plasma exchange once you have started it, as the continued production of the autoantibody doesn't stop once you stop the plasma exchange. Then there's the anti-complement therapy with eculizumab, which is an anti-CD5 convertase agent, and several case reports and a few case series support the use of eculizumab, and KDIGO does recommend it as a therapy option once all other therapy has failed. Once again, the results from different clinical trials, case reports, and case series are varied, and some patients have benefited while others have not. And this varied response reiterates the different subsets of the disease and that specific therapy regimes are likely needed to effectively treat all of these patients. There are currently ongoing trials looking at the specific subsets of the disease and eculizumab to ensure exactly where it could be beneficial. The main issues that we face with the use of eculizumab is obviously, when is it too late to use eculizumab? Should we be using it in patients with low GFRs already? The next question is the cost. So at the moment, it's $6,878 each month for the treatment with eculizumab. So obviously, in a disease with ongoing antibody production, do you continue with lifelong therapy for $6,878 a month? I don't think so. So this diagram just shows us nicely at which point eculizumab does work in the complement cascade, and that there are alternative therapies which are being studied, namely avacopan, who is also inhibiting the C5 convertase. There are newer agents that are being investigated in clinical trials, and some of them have started recruiting patients for their clinical trials or started treating patients in their clinical trials. But as all the subsets of this condition are very small in number, we don't yet have any research to back us up in the treatment of any of these agents. So as you can see, most of these agents work on the prevention of formation of C3 and C5 convertase through the inhibition of factor D and factor B, and also the reduced production of C3 convertase. And these would all act at this point in the complement cascade. So the 1C3 convertase, anti-convertase agent, which is currently in phase 3 trials, is pegcetacoplan. And this is a cyclic peptide related to comstatin, which blocks C3 and prevents the generation of C3b and subsequent loading of C3b onto the red blood cells, and therefore stops the rest of the complement cascade. And it works basically all the way up here in the complement cascade. So if the treatment fails and we're unable to preserve renal function, then I guess we move on to our trusty friend, dialysis. And as you know, dialysis slots are just around every corner So obviously dialysis is not the end goal in renal replacement therapy. And with this disease, we are left with questions such as, does a kidney transplant cure this disease? And is there recurrence post-transplant? And the data on outcomes, once again, are very sparse. The largest trial contained 21 patients, of which 14 patients had recurrence of disease confirmed on biopsy. Currently, we're not sure how to prevent the recurrence, and there is some evidence that eculizumab can be used for prevention and can also be used once you get recurrence. Once again, 6,878 rand. You don't know when to stop it. You don't know when to give it. Don't know if it's the best use of money. Then you can also consider a liver transplant, and they suggest that this be considered specifically in patients with liver-derived complement abnormalities. And there are numerous case reports who have basically reported that this is an efficient manner to manage this disease. Very importantly, with these patients, if you do consider them for transplant, you should avoid a related living donor, as basically the patient's donor may have the same pathogenic variant and cause the same disease once they get transplanted. So what's happening with our patient? We've excluded all infectious, autoimmune, or monoclonal gammopathies as the etiology of the C3 gene infant. He still has continued proteinuria and his GFR has started dropping. So we have admitted him to try and measure his autoantibodies and inhibitors with the help of our friends at Immunology. We've decided to start him on a trial of cyclophosphamide therapy. And this is basically just because there are limited dialysis slots available in our setting. So we'd rather try some therapy than nothing.